really excited to welcome Dr. Scammell, Dr. Tom Scammell here today. He is a professor of neurology at Harvard Medical School, and he really focuses on sleep. And as we know, sleep is such an important thing for our kids. We know that in PWS there is a disruption of sleep, and that can contribute to so many things. Just think of us when we haven't had much sleep, a little bit grumpy, eating things that we probably shouldn't eat, and clearly it also affects metabolism. It clearly has probably an underappreciated impact on the severity of PWS. Dr. Scammell does research in the area of sleep, so he works on some of our favorite molecules, oxytocin, orexin, and how those molecules impact sleep. He's also a clinician, and he studies individuals with sleep disorders, so he brings both a basic science background and a clinical knowledge to the problem of PWS, so we're really excited to have him come talk to us today.
All right. Well, thank you all for inviting me. It's great to come. And I have to say, I'm relatively new to the Prader-Willi field. We've had funding from the foundation for the last year, and we've now just gotten a second year of funding. But my background's really in narcolepsy, but I think some of you might appreciate that some of the features of narcolepsy overlap with those of Prader-Willi, and so that was really sort of my connection point. And they're both essentially, to a great degree, diseases of the hypothalamus, and I'm going to tell you a little bit about some of those connections as we go through. So I don't really need to emphasize this to y'all, but it's certainly clear that sleep issues are a real problem for many people with Prader-Willi. Daytime sleepiness is extremely common. When I look through the literature, when you ask people just to sort of self-report, it's as high as 90% of affected individuals can have problems with daytime sleepiness, though in some other surveys it may be about 50%. And then sleep apnea, of course, is really common. And what's interesting about the sleep apnea, we'll get to this in a little bit, is that we often tend to think of sleep apnea as being a problem in obese individuals, but I think there's probably some independent risks in Prader-Willi that maybe make them more prone towards having issues around their breathing during sleep. And one of the most striking things is that some, maybe 1 in 5 people with Prader-Willi can have these episodes that look a lot like what we see in narcolepsy, something called cataplexy. And I'll show you a video of what that looks like in a little bit. But it's a very unusual symptom, and I'm hoping that it might be a sort of a toehold into understanding what's really going on in the brain that contributes to all of these things. So what I'd like to do in the next 30, 40 minutes is to review some of these sleep issues that occur in Prader-Willi, to talk about sleep in a mouse model that we've just been studying, and then to turn around and talk about how do we put some of these ideas into practice and pick the best treatments for folks who do have Prader-Willi. So over the course of the night, if you're a good sleeper, your sleep might look sort of like this. This is what we call a hypnogram, and it's a graphical way of showing a typical night's sleep. And so here what you can see is an individual going to sleep around midnight. On the y-axis are the different stages of sleep. A wakefulness. We then break the deeper stages of sleep into stage 1, 2, 3, 4. That's non-REM sleep. That's when you're not dreaming. It's sort of, you become increasingly unconscious in those deepest stages of non-REM. And then as the night progresses, people start to have REM sleep, rapid eye movement sleep, and that's dreaming sleep. And so if you wake somebody up out of REM sleep, there's about an 80% chance they'll describe to you some long, complicated dream with crazy stuff happening. But if you wake somebody out of deep non-REM sleep, quite frequently you say, what were you thinking about? And it's like, nothing. It's just complete darkness. In the lighter stages of, like stage 1 and 2 of non-REM, sometimes there's some kind of smoldering, boring mentations. But certainly in deep non-REM sleep, people are unconscious. In REM sleep, you really see a lot of dreaming. One of the things about REM sleep that's relevant to our talk today is that not only are you dreaming in REM sleep, but people's bodies are paralyzed. You can still breathe, but limb muscles and stuff like that are really completely inhibited. The motor neurons that control them are shut down so that you cannot act out your dreams. There's actually a disease where that control system is messed up. It's not relevant to Prader-Willi, but where people actually act out their dreams. It's not sleepwalking, but it's even more sort of vigorous and crazy looking, and that can cause some real problems. Anyway, so REM sleep is dreaming and paralysis. So if you look at the sleep of folks with Prader-Willi, they, over the course of a day, many of them, it seems, are more likely to have greater than the usual amounts of sleep. We think that the average adult needs about 7.5 to 8 hours of sleep, but adults with Prader-Willi are often reported to have more than 8 hours of sleep, and it's felt that maybe 20% of them will actually sleep for maybe 10 hours or more per 24 hours. We don't really understand where this comes from. And the nighttime sleep can be disrupted. And so sleep apnea is certainly one of the more common things, and that's true in the general population, and it may be particularly true in the Prader-Willi population. But there can also be issues around initiating sleep. I mean, if there's behavioral problems, if there's anxiety, the kind of things that would make it hard for any of us to sleep, and those may certainly just be more prominent in Prader-Willi. Early morning awakenings can be an issue. And again, there can be behavioral factors. I suppose hunger could be one of those as well. And then issues around depression. Certainly when people are depressed, it's very common for them to wake early in the morning. There's also a hint that circadian rhythms may be disrupted in Prader-Willi. And so, circadian rhythms are these internal body rhythms where your sleep-wake cycle, your daily rhythm of hunger and activity and so forth just will continue to tick along independent of any outside cues. So they're internally generated. And so in the most extreme example of this, there was experiments done in the 30s and 40s where they literally had folks go down into Mammoth Cave and just follow their own schedule. And what you saw is that people would sleep and wake about every 24 hours. It would be sort of the typical rhythm that we see in our day-to-day lives, and it's driven by an internal clock. And so even in the absence of social cues and light cues, those internal circadian rhythms keep ticking along. The feeling is that in Prader-Willi, there may be a blunting of those rhythms, and so the normal drive to wake in the day and to sleep at night may be a little bit attenuated. And this is not, I don't think we really have good data on this from a clinical population, but in a mouse model, these MAGE L2 null mice, they seem to have a blunted circadian variation. Normally, mice are very active at night, and these mice are less active at night and maybe more active during the day, so they don't show that clear day-night distinction. So getting back to the issue around daytime sleepiness, as I said before, it's a super common symptom. And one of the ways, we can measure this in questionnaires. You can just ask people, how sleepy are you? How likely are you to fall asleep under different circumstances? Or we can measure it objectively by something called the multiple sleep latency test. And this is a test that was pretty much invented, actually it was invented right around here at Brown University. And it's a test where 5 times across the day, you ask people to try to go to sleep. They lie down, turn out the lights, comfy bed, and you see how fast they fall asleep. A well-rested, healthy individual would take at least 15 or 20 minutes to fall asleep during those 5 nap opportunities. But amongst folks with Prader-Willi, on average, they fall asleep in about 7.5 minutes across those 5 nap attempts. And so they can consistently fall asleep, and they fall asleep quickly. So that's objective evidence of their daytime sleepiness. And again, we don't really know where this comes from. It could be a consequence of poor nighttime sleep. We don't really have much data on this one way or the other. But another possibility is that maybe there's something in Prader-Willi that's a bit like narcolepsy. And I'm going to talk about this very briefly later on, but narcolepsy is another neurologic disorder where people have severe chronic sleepiness. But in contrast to Prader-Willi, we actually have a very good understanding of what causes narcolepsy. Narcolepsy is due to a loss of one type of neuron in the brain. It produces a neurotransmitter or a signaling molecule in the brain that's called orexin. It's also called hypocretin. And the reason this is interesting is because in Prader-Willi, as I'll show you in a little bit, orexin levels are a bit low. And so while it's not necessarily full-blown narcolepsy picture, it may be kind of like a mild partial narcolepsy due to lowish orexin levels. And as I mentioned before, there's these circadian rhythms where there's a circadian rhythm that drives wakefulness during the day. If you stay up all night, you're going to feel really sleepy around 3 or 4 in the morning. But if you continue to stay awake, you'll actually probably feel better around 10 o'clock in the morning. And the reason for this is there's a circadian waking drive that can help offset any sleep pressure that's accumulating. And it's possible that that circadian rhythm of arousal or wakefulness is attenuated in Prader-Willi. I have to say, all of these are just sort of ideas, and they're actually perfectly great ideas to pursue in clinical research if people think they're important. But as you heard in the introduction, insufficient sleep or bad quality sleep has all kinds of consequences. We don't know much about how nighttime sleep quality impacts on daytime performance in Prader-Willi, but certainly in an otherwise healthy general population, there's a lot of consequences. There's the things that we're all sort of familiar with of cognitive impairment and so forth. And what's interesting is I think a lot of these specific things that have been studied so much, I think you'll see that they resonate in the Prader-Willi population. And so, for instance, executive function, This is what your frontal lobes do, making executive decisions, working memory, impulse control, judgment, insight, stuff like that. Those are the things that suffer first when people are not getting enough sleep. Inattentiveness, of course, just being spacey and having trouble staying focused. And so sleepy people don't do well in school. And of course, for folks who are driving, we worry about drowsy driving and motor vehicle accidents. And most of that's from attention, though sometimes there's actually micro-sleeps where people will nod off for a few seconds. Insufficient sleep affects people's mood. We don't need to go over that. Everybody gets grumpy when they're tired, much more likely to get into a fight. And then, of course, in children, sleepiness can present in a very sort of paradoxical way, where instead of saying, hey, I'm sleepy, and their eyes are closing, they go crazy instead, and they're running around hyperactive, and they're irritable, and they're inattentive. And so sometimes, I was the medical director of the sleep clinic at Children's Hospital for a couple of years, and, sometimes we'll see kids who get diagnosed with attention deficit disorder, and they don't have ADHD at all. What they have is a sleep problem, and you fix their sleep apnea, you fix their sleep schedule or whatever, and their supposed ADD improves. So important to recognize that it's a different presentation in kids than in adults. Even in a normal, healthy population, not sleeping well at night can make people prone towards obesity. And so if you take a really great experiment done by Ev von Kauder at University of Chicago, they took a bunch of adults, young adults who were healthy 8-hour sleepers, cut them back to 4 hours of sleep for about a week or so. And what you saw is that they started producing less leptin. Leptin is made by fat, and when your leptin levels go down, your brain thinks you're starving. And these same people started producing more ghrelin, and ghrelin's a hormone made by the stomach that increases appetite. And so you get these two things. You have a signal saying, hey, your body's starving, and another one says you're hungry. And so people would tend to eat more. And what's interesting is partially because of that poor executive function, when given a choice of foods, sleepy people tend to eat junk food. They'll eat more carbohydrates, they'll eat fatty stuff. This is when you eat a whole bag of potato chips at 11 o'clock at night without even thinking about it. And diabetics can also have worse glucose control when they don't get enough sleep either. And so insulin regulation of glucose levels is messed up a bit. The sympathetic nervous system, the fight or flight system, is also disrupted with insufficient sleep, and so people are more prone towards having high blood pressure and a higher heart rate when they're not getting enough sleep. And what your mom told you when you were little is true as well, that immune function is very dependent on sleep. If you don't get enough sleep, your immune system doesn't work so good. One lovely study along these lines is they took a bunch of young, healthy people and gave them all the flu vaccine. Half of them then got their usual 8 hours of sleep at night. The other half got 4 hours of sleep at night. The ones who got only 4 hours of sleep had antibody levels 2 weeks later against the flu that were only half as high as seen in the well-rested people. And so getting that sleep after that immune challenge, in this case the flu vaccine, clearly can make a difference in how the robustness of your immune responses. And I think we've all sort of had those circumstances where you're just working like a dog and not getting enough sleep, and suddenly you just get incredibly sick, and it may tie into this. So sleep apnea is something that probably should be at least discussed in, I think, pretty much anybody who's got Prader-Willi. It's a super common thing in the general population. About 5% of adults have Prader-Willi, and it's about 5% of children. 5% of adults have obstructive sleep apnea, and 5% of children also have obstructive sleep apnea. But if you look at the Prader-Willi population, it's something over 70%, maybe as high as 90%. And if you sort of some of them it's just mild, but 20% of them probably have severe sleep apnea. And severe sleep apnea is something where in clinic we would yes, absolutely, this needs to be treated. The usual presentation is loud snoring, pauses in breathing. Occasionally the person will gasp. Some of you may have a bed partner who has sleep apnea, and you know what I'm talking about. It can be very disruptive. If it's disrupting your sleep, just think of what it's doing to their sleep. And basically what happens is that people block off their airway, and they're not getting enough oxygen, and they have to wake themselves up. And sometimes with bad sleep apnea, people literally rouse themselves from sleep every minute across the night. It's just like being poked every minute, and they have to rouse a little bit to restore their airway. And so the usual picture is obstructive sleep apnea, where the airway is being blocked off. It's most typically seen with obese individuals, people with a big, thick neck, a crowded airway from a big tongue or a long, soft palate. Big tonsils, big adenoids can contribute, nasal congestion and allergies. And if somebody's got scoliosis, that can also make it worse too, because their lungs just aren't quite as expanded. So in obstructive sleep apnea, the issue is airway obstruction. People are trying to breathe, but as their muscles relax during sleep, those tissues get in the way and they can't breathe well. In central sleep apnea, it's a central nervous system problem. And so there's nothing wrong with the airway anatomy, but the brainstem's commands to take breaths are not quite right. And so this occurs in about 20% of people with Prader-Willi, where there's some problem with the central regulation of breathing. And so you'll see that there's poor effort to breathe, even though the airway is open. And this may tie in with the issue of low muscle tone, in the sense that when people go into rapid eye movement sleep, remember your whole body's paralyzed? And it's possible that there's also some impairment of the respiratory muscles, at least in some occasions. So central sleep apnea more common in REM sleep in this population. So we treat sleep apnea and Prader-Willi much the way we do in the general population. I mean, the first thing to do is an overnight sleep study, a polysomnogram, and this can be done in little kids to adults. And it will give an unambiguous answer of whether there's any sleep apnea. The trouble is it kind of comes in shades of gray. And as I said, if somebody's got severe sleep apnea, there's no question it really should be treated. If it's kind of mild, then one of the challenges is, these therapies are not always so easy to tolerate, and so sometimes it's a question of how much benefit is to be gained by treating mild sleep apnea versus the grief of the treatment. We'll get to those treatments in a second. The issue of diagnosing sleep apnea really comes up around the question of growth hormone. I think many of you are familiar with the fact that growth hormone is being used a lot in young kids with Prader-Willi now, but growth hormone can actually cause the tonsils to enlarge. And if, in children, big tonsils are actually a very common cause of sleep apnea. And so for many kids with sleep apnea, the first thing you do is you take the tonsils and adenoids out. And so it's pretty important to keep an eye on a kid's breathing when they start on growth hormone. And sometimes, you may want to, the family and the doctor may want to work together to maybe do a sleep study before growth hormone and then the several months afterwards just to make sure that there's no worsening of breathing. One of the advantages is that in the long term, it seems that children who get treated with growth hormone actually have less tendency towards these central sleep apneas, as well as many other benefits from the growth hormone. So the treatment for sleep apnea is, particularly in children, tonsillectomy. Getting your tonsils out when you're 5 years old isn't such a big deal. Getting them out when you're 25 is actually a really big deal. For whatever reason, it's just sort of a much more morbidity, a lot more sore throat. It's hard to eat for a week. Kids tend to bounce back faster. In adults, we use continuous positive airway pressure a lot. This is a mask that goes over the nose or the nose plus mouth, and it's connected to a machine that blows some air. And that air literally inflates the airway. It pushes those obstructing tissues out of the way so that people can breathe better. It really works. Physiologically, it helps like over 90% of people with sleep apnea. The downside is it's kind of clunky. When we prescribe CPAP to an otherwise healthy population, at 1 year, only half of them are still using it because it's a pain in the neck to put this mask on. And so one of the really important things that I would encourage you all to think about is it's really important to work with a sleep specialist, I think, if somebody's going to be using CPAP, because there's literally 100 different kinds of masks, there's all different kinds of machines, and there's many ways to make it tolerable. But it is the safest and most effective therapy that we have for sleep apnea. Occasionally, if somebody's got mild sleep apnea, we'll give them a dental device that simply moves the jaw forwards a little bit. It's kind of like those retainers that people wear when they grind their teeth. And then, of course, weight loss can help too, though it's unusual, at least in the adult population, for people to lose enough weight to really make their sleep apnea that much better. But here's the mystery. Even though sleep apnea is common in Prader-Willi, even when it's treated seemingly in an optimal way, the sleepiness often persists. It may get better, but there's still some sleepiness. And that really suggests that it isn't just the sleep apnea. There's probably something else going on, some intrinsic problem in the brain that may be causing sleepiness independent of these other factors. And this is where this whole story of sort of a connection to narcolepsy comes in. And so narcolepsy is this disorder it's seen in about 1 in 2,000 people, and it's characterized by sleepiness and messed up REM sleep. And so the dreams of REM sleep can occur at the very beginning or end of sleep and manifest as hallucinations, or people can have the paralysis of REM sleep occurring right in the middle of wakefulness, and that's called cataplexy. And I'll show you a video of what that looks like in a second. But in Prader-Willi, as I mentioned before, there's, the daytime sleepiness is certainly very common, and they do show some abnormalities of rapid eye movement sleep. So they can enter REM sleep very quickly at night, and if you do that multiple sleep latency test where you're trying to have them fall asleep on 5 occasions across the day, about a third of the time, an individual with Prader-Willi will show REM sleep during those naps. In an otherwise healthy person, there's no REM sleep during the daytime. It's sort of against the rules of the brain to produce REM sleep in the day. But in narcolepsy, and then occasionally in Prader-Willi, you see REM sleep breaking through. And about 20%, as I mentioned, have these episodes that look a lot like cataplexy. The reason I call them cataplexy-like is because we just don't actually have great data on this. One of the things I think that we might have talked about on the phone is how great it would be to actually just collect videos from people and just look at, 20 or 50 videos from different kids who are having these episodes of weakness to try to get a good sense of describing these episodes. I'll show you what classic cataplexy looks like in a second, and if we have time, we can look at a video of a Prader-Willi kid as well. But in its classic form, cataplexy is sudden episodes of muscle weakness that's brought on by strong emotions. And so somebody with otherwise normal muscle tone will be laughing at a great joke and then suddenly slump to the ground. In fact, I'm going to just skip ahead to this movie and then we'll flip back again. So this is a video of some young kid about, this audio is horrible. Let me see if I can get rid of it. So try to ignore all the laughter in the background. This kid's Czechoslovakian, by the way, which explains the Slavic dance. There's a little editing glitch coming up here in a second. But this is an episode of cataplexy where the kid gradually loses muscle tone over the course of several seconds, and he's awake. He's not fainting. It looks like a faint, but it's not. Consciousness is completely preserved. I've had patients do this in clinic, and you can give them a long string of numbers to remember, and they'll be able to recite it to you a minute later when they're feeling better. And so it's a loss of muscle tone, and we think this is the paralysis of REM sleep breaking through into wakefulness. Most of the time when people have cataplexy, they don't go down that hard, but this poor kid has some episodes that are really terrible, and he bonks his head occasionally. So it's sudden episodes of muscle weakness. In its severe form, it affects the whole body. When it's mild, it may just affect the face and neck or the limbs, and the kid will look floppy. Their speech may be slurred, their head may loll forwards, their eyes are closed. But the important thing is they're not sleeping, they're not fainting, they're actually awake. And what I wanted to point out here is that just recently, there was a little hint of this some years past, but just recently there was a very nice paper that came out looking at Orexin levels in people with Prader-Willi and comparing them to some other groups. And so what we're looking at on the bottom here is spinal fluid Orexin levels from 3 groups. I don't know if you guys can read the labels at the bottom there, but this is really dim. Idiopathic hypersomnia is a kind of sleepiness that we don't have an explanation for, but essentially these people have normal Orexin levels. They're around 300 picograms per milliliter. In narcolepsy, 90% of the time, Orexin levels are super low, down at the sort of detection limit of around 40 or 50. But in Prader-Willi, what you can see is that there's a fair range, but they're all sort of in this intermediate range. They're never above 300, which is the average for otherwise normal individuals, but they sort of average around 200. And so I think that, my current impression of all this is that what we're seeing in Prader-Willi is kind of a mild partial cataplexy, a partial narcolepsy, where there's some degree of orexin deficiency, not as severe as what's seen in classical narcolepsy, but definitely low. And so what that results in, I think, is sort of like a mild partial narcolepsy picture with some sleepiness, some episodes that look like cataplexy, with obviously some variation between people. So I want to switch gears now and just talk about some of the work that we've done over the last year trying to understand this sleep phenotype in a mouse model of Prader-Willi. And so again, this was funded through the foundation, and we're very appreciative of that. And what we decided to focus on is these MAGEL2 null mice. This is one of the genes that's disrupted in Prader-Willi syndrome, and this mouse model was developed by Rachel Weverick and is very well characterized. There's a lot known about these animals in many different ways, and so we felt they'd be a good one to start with. As you know, there's lots of different genetic things going wrong in Prader-Willi, and this is just one of many genes that are relevant. And I should also mention that we thought this was going to be the first description of sleep in a mouse model of Prader-Willi, but there's actually another paper that just came out early this year of a mouse with an abnormality in one of the SNORD genes. And what's interesting is their findings kind of complement ours. I'll talk about that a little bit at the end. So we're looking at mice with sort of just a problem in one of the genes that's relevant to the whole Prader-Willi picture. And so these MAGE L2 null mice have features similar to Prader-Willi: poor feeding at birth, impaired reproduction, blunted circadian rhythms. They don't socialize as well with other mice. It looks sort of like autism-like behavior. And they also have low orexin levels. And so our hypothesis was that these mice would have a sleep pattern that looks a lot like the narcolepsy one, that they would have sleepiness, they'd have fragmented sleep, and they would have these episodes of cataplexy as well. Our hope is that if we could actually capture this pattern in these animals, then we could actually dive in and try to figure out what the underlying pathways are so we could ultimately come up with better treatments. And so this work was done by Carrie Mahoney in my group, and she spoke at the Prader-Willi meeting up in Toronto some months ago. And what she found was that these MAGE L2 mice do have some abnormalities in their sleep. They fall asleep quicker and they wake up more frequently than they should. And so what this is showing, there's a lot of data packed on this one slide here, but mice are nocturnal, so they're mainly active at night. And so up top here, this is showing the total amount of time spent in wakefulness, non-REM sleep, and REM sleep. And the normal mice are shown in blue. Those are called wild types. And the MAGE L2 mutant animals, the Prader-Willi-like animals, are shown in this bright green. And basically, the total amounts of wakefulness, non-REM sleep, and REM sleep are the same. But the MAGE L2 mice have more frequent bouts of wakefulness and non-REM sleep and REM sleep, and the duration of those bouts is shorter. And so what's happening is the mice are flipping back and forth between states quicker than they should. And we see this in sleepy animals, just like in sleepy people, where you can't stay awake as long. But what's interesting here is they don't sleep for a super long time either, so their sleep is fragmented. And then during the light period, which is mainly their sleep period, we see the same pattern. Again, wake bouts are shorter, non-REM bouts are shorter. The more numerous, and the wake bouts and the non-REM bouts are shorter on the right-hand panel there. So there's a fragmentation of sleep-wake behavior. We wanted to try to get a sense of, well, where's this tendency to fall asleep so quickly coming from? And so we looked at the details of the brainwaves, the cortical activity in these animals. And so we used the electroencephalogram, just like in humans. We measured the electrical activity on the surface of the brain. And that electrical activity is really complicated, but we can break it down into a whole bunch of different frequencies that contributes to this. And I'm sorry, this is the most technical slide I've got up here. But basically on the x-axis, this is showing activity in different frequencies, ranging from 1 hertz up to 6 to 11 hertz and so forth. And what we see in the MAGE L2 animals is that during non-REM sleep, let me tell you about wild-type normal mice first. In normal mice, in non-REM sleep, you see lots of slow activity. That's typical. But in the MAGE L2 animals, we see more of it. During the light period, it's not so striking, but during the dark period, these mice, when they do fall asleep, they're showing deeper sleep. And so when you see an increase in those slow frequencies, it's indicative of those super deep stages of sleep, the ones that are hard to wake up out of. And so what we think is happening with these animals is that they have a higher sleep drive. When they fall asleep, they're going into a deeper sleep, and that's why they tend to fall asleep so frequently. Studying cataplexy in mice is a little bit complicated because what we really want is we want to bring out episodes of muscle weakness that are triggered by positive emotions. And so that requires us to think about what is it that would make a mouse really happy. And so what we tried is a few things that work really great in narcolepsy mouse models. And so we found previously that compared to regular chow, highly palatable foods like Fruit Loops, peanuts, things like that, can increase cataplexy. And the thing that really increases it the most is chocolate. If we give a narcoleptic mouse 1 Hershey's Kiss, they will have 8 times as much cataplexy. So we tried the same thing with these MAGE L2 mice, and they didn't. We didn't see any cataplexy in them. And so what's my bottom line is that I think that these animals, remember, this is only one of the many genes that's altered in Prader-Willi, and so it's no surprise that they might not capture all of the features of the sleep behavior. And so if you look at people with Prader-Willi, there's issues around sleepiness, frequent awakenings, these cataplexy-like episodes, and sleep apnea. And in the MAGE L2 mice, they've got the sleepiness and the frequent awakenings. I'm pretty confident to say they don't have any cataplexy, and we didn't test them for sleep apnea, so I don't really know that. We tested a couple mice, and we didn't see any, but we didn't go at it as thoroughly as we should. And so, as I mentioned earlier, there is this other group that was looking at these snored mice, and those actually do show REM sleep abnormalities. Whether they show cataplexy, I'm not so certain. They have one figure in there that makes me think there may be cataplexy in the snored mice. And if that's the case, that would be kind of cool, because then you could imagine that between the MAGEL2 gene and the snored gene, you may actually capture the whole picture of messed up sleep in Prader-Willi. Now, as you heard briefly, so that's what we worked on in our first year of funding. And in our second year, which is now coming up, we're going to be looking at oxytocin. And one thing that people haven't appreciated, obviously you guys are familiar with the fact that oxytocin is sort of the social hormone. It's really relevant in anything that has to do with autism. But we've actually just found that oxytocin plays a really important role in sleep and wakefulness as well. And so what we're going to be doing in this coming year is to try to get a better understanding of how is it that lowish oxytocin tone, which is the case in Prader-Willi, contributes to sleepiness. Because one of the things that we discovered is that if we stimulate the oxytocin neurons, we get tremendously strong arousal responses in these mice. And this is something that people haven't really talked about much before, that in addition to being a social hormone, oxytocin may also contribute to arousal. So it may well be that part of the picture is lower orexin levels, but another part of the picture may be low oxytocin tone as well. So hopefully we'll have more news on that in the coming year. All right, so I want to switch gears and talk about treatments, because this is obviously something of great practical importance. Our challenge here is that there's been very little formal research done on how do you manage sleepiness and other sleep abnormalities in Prader-Willi. And so I think most sleep specialists and sleep clinicians pretty much go with sort of the standard stuff. For most people with sleepiness, we often turn towards amphetamine-type drugs like Ritalin and Dexedrine. I think these are potentially kind of an issue in the Prader-Willi population. If you've got a kid who's already anxious or has a tendency towards OCD, or who perhaps isn't even really sleeping all that great at night, giving them an amphetamine might well make things worse. So as I talked to a few doctors who were treating Prader-Willi kids, and they said they really look at the amphetamines as a second-line choice. In narcolepsy, we use them as a first-line choice, but we're not dealing with the same psychological and psychiatric comorbidities. And of course, anyway, so I think the concern about worsening behavioral problems is probably one of the great barriers to using these type of medicines. And so up until around the year 2000, this was really pretty much the only thing that we had to improve arousal. And then around 2000, modafinil came out, and then about 5 years ago, armodafinil came out. So the brand names for these are Provigil and Nuvigil. So when you buy Provigil, you're actually buying a mixture of two drugs. A lot of chemicals come with sort of mirror images of each other. They're called the R and the S enantiomer. And it turns out that the R enantiomer of modafinil is the active form. The S enantiomer doesn't do anything. So when somebody's taking modafinil, half of the stuff they're taking doesn't actually do anything. It's just ineffective. And so about 5-10 years ago, companies learned how to purify the active form, and that's the R-modafinil. And so Nuvigil is just simply, if you will, a more concentrated, potent version of modafinil. All right? Same drug, different package, basically. And so the dosing's a little different just simply because it's a more concentrated form. So modafinil, in many ways, is a really useful wake-promoting medication. It has generally very few side effects. Occasionally we see some little things like maybe 15% of people can get headaches, maybe less than 5% get nausea. But the psychological stuff that you might see more frequently with the amphetamines is actually much less common. I would say less than 1% of people treated with modafinil will have any worsening of anxiety or OCD and things like that. It has one sort of dreaded side effect. It only affects 1 in 10,000 people, but it can produce a really horrible rash, which can actually be life-threatening. But that's very, very rare. In general, it's a well-tolerated medicine. The downside with modafinil is that it's not as potent as we would like. In very sleepy individuals, amphetamines tend to actually have more kick to them than the modafinil. Many people say that modafinil feels a bit like 2 cups of coffee without the jitters. But so it's good for mild to moderate sleepiness. It doesn't cut it when somebody has severe sleepiness. Now, cataplexy we treat with antidepressants. And the reason is because antidepressants reduce REM sleep. And so we use venlafaxine, fluoxetine, which is Prozac. And then we don't use it so much anymore, but clomipramine, anafranil, is one of the older antidepressants. And all of these are very effective at suppressing cataplexy. I don't know of any published work showing that they can affect the cataplexy-like behavior in Prader-Willi, but they certainly are helpful in narcolepsy. And at least a couple clinicians that I talked to said that they've tried these in Prader-Willi, seemingly with some success, because we think it's the same underlying mechanism. They're generally all tolerated pretty well. The clomipramine is kind of the worst of the bunch because it can cause a dry mouth and constipation and stuff like that. So one drug that's gotten a fair amount of discussion recently is this new wake-promoting medicine called pitolisant. In the older papers, you'll see it also referred to as T-prolisant, but the newer name that's generally used is pitolisant. And this is different than the other medicines that we've talked about. Let me just back up a little bit. So with these old medicines, the amphetamines increase wakefulness by increasing brain levels of dopamine predominantly, but they also increase norepinephrine and serotonin. And the dopamine's good because the dopamine promotes wakefulness. The norepinephrine can be kind of a problem because people can feel anxious, and the serotonin can affect mood. Modafinil, in many ways, is a cleaner drug because it predominantly increases dopamine levels in the brain. Pitolisant acts on the histamine system primarily. How it actually works is a little bit complicated, but there's the histamine neurons in the brain also promote wakefulness, like those other chemicals I just talked about. When you take an old-fashioned antihistamine like Benadryl, it makes you sleepy because it's blocking the normal wake-promoting effects of histamine. The neurons that make histamine have a receptor on them called the H3 receptor, through which histamine shuts down the activity of those cells. So it's auto-inhibitory, if that makes sense. And so when histamine levels get high, the histamine acts upon the H3 receptors to shut down the histamine system. So it's putting brakes on the system. And somebody said, well, what if we take the brakes off? What if we make a drug that blocks that H3 receptor? That'll allow the histamine system to be much more active. And that's indeed the case. And so if you give animals this pitolisant, their brain levels of histamine will be higher, and the animals will be awake more. But it's not that simple, because as it turns out, the norepinephrine, the dopamine, and the serotonin neurons also have H3 receptors on them, and so you're taking the brakes off of those cells as well. And so not only do you get more histamine, but you get more norepinephrine, more dopamine, and more serotonin. So in some ways, this drug, while it's advertised as being sort of a clean histamine drug, may actually be about as messy as the amphetamines. We don't really know this yet. We don't know enough about the side effect profile to see if it carries the same baggage as the amphetamines, but it's certainly one of those things you got to think about. So anyway, so histamine is a wake-promoting thing, and when people have measured spinal fluid levels of histamine, they're lowish. In narcolepsy sometimes. It has not been studied in Prader-Willi yet, to my knowledge. And I just pretty much covered that. Pitolisant is now sort of available in France on kind of an investigational basis. It's not available in the US or Canada. However, it does work. On the right is a graph showing Epworth sleepiness score. So this is a subjective measure of sleepiness. Scores can go as high as 24. That would be extremely bad sleepiness. And all of these individuals, this is a study of people with narcolepsy, and all these individuals are starting off with levels of sleepiness in the 18 to 19 range. They got assigned to 3 different groups, a placebo group, a pitolisant group, and a modafinil group, and then their level of sleepiness was evaluated over the next several weeks. And what you can see is that in visits 4, 5, 6, and 7, you see these gradually decreasing levels of sleepiness. And overall, pitolisant looks about as effective as modafinil. So I have no reason to think that pitolisant is necessarily better than modafinil. If anything, I think it actually could potentially be more problematic because of the fact that it kind of unleashes more neurochemical systems in the brain than modafinil does. But we just really need to know. There needs to be trials of this. We need more work both in narcolepsy and in the Prader-Willi populations to get a sense of the side effect profile and really get a good sense of its safety and how its efficacy compares to the other medicines that are already out there. Now, I told you about how in narcolepsy, orexin levels are really low, and how in Prader-Willi, they're moderately low. And so what we would really love are drugs that mimic the effects of orexin. These are not available yet, but the goal is to try to come up with an agonist. That is a drug that mimics the effects of the natural orexin, because if you could restore normal orexin signaling in the brain, it would be like giving insulin to somebody with diabetes. It would be great because you're actually replacing the thing that's missing. And so we anticipate that these could be very effective. As it turns out, designing these is super hard. I've been talking to pharmaceutical companies for the last 10 years about this, and for years and years they said, no, impossible, we can't possibly do it. And then last year, somebody published a paper showing that at least in sort of one circumstance they can do it. And so now they're actually putting millions of dollars into this because they see this as a potentially useful way forward for a very new kind of wake-promoting medication. The hope is that it would avoid a lot of the side effects that are seen with some of these other medicines. But we don't know enough about the Orexin system to say that this is going to be completely safe and so forth. I do worry that one could get insomnia or mania from this medicine. It could potentially have some abuse potential. You might be more awake, but it might feel too good. And we worry about heart rate and blood pressure and weight loss. And I think we just need to wait until the clinical trials are done to get a sense of whether these things are going to really work. So I just wanted to leave that as kind of a ray of hope for the future. These orexin antagonists, if the current efforts pay off, I could see these going into human clinical trials in the next several years and maybe being available in clinic potentially as soon as 5 years from now. So just to wrap up the main points of what we've talked about, we talked about how daytime sleepiness is super common in Prader-Willi and how we don't really know what causes this sleepiness. In part, it might be due to the sleep apnea. It might be due to crummy nighttime sleep. Maybe the low orexin levels contribute. But then also about 1 in 5 people have these episodes of cataplexy, and that sort of bolsters the case for some abnormality in orexin signaling. And the MAGEL2 gene might contribute to the sleepiness of Prader-Willi. And we talked about treatments. Modafinil, I think, is really the first line at this point, and one could consider amphetamines in a very careful way. Just wanted to acknowledge the folks who've actually done a lot of the frontline work on this. Carrie Mahoney, that some of you might have met up in Toronto, did a bunch of the stuff with the MAGEL2 animals. And the other folks highlighted in blue have also contributed to this. And then our funding over the last year has been from the Foundation for Prader-Willi Research. So thank you all for your attention.
Questions for Dr. Scammell? Sure.
Hello?
Yeah.
Hi. That was amazing. Whoa. That was very good. Thank you. A lot of information. We tried Provigil on our son, and it did increase anxiety, so we took him off it. After hearing your speech, I'm thinking maybe do we revisit it? Because maybe it was just a time in his life.
How old is he and how much was he taking?
So he was, I think, 8, Keegan, at the time. 8 or 9, and I think he was on 50 or 100, I can't remember because it was 3 years ago.
Yeah,
So right now he's 11 years old, so we might need to revisit it. What do you think of that?
Yeah, no, I think it's, so sleepiness is an ongoing issue for him.
Yeah.
Yeah. So as I said, I think it's sort of one of the safest things we've got out there as far as various options. And people change over time. It may well be that now that a few years have passed, his brain is more mature in some ways and that he would handle it better. But certainly, I think the idea is to start with a low dose. And the 50 or 100 milligrams is a completely reasonable dose for his current 11 years old. And, maybe it just hit him a little hard when he was younger. Okay. So, but yeah, I would work with a sleep specialist on it and just kind of tiptoe, just go with little low doses. And it also might be useful to, that Epworth sleepiness scale is like super easy to do, and you could actually just sort of keep a log of the level of sleepiness and have some objective data that you can collect alongside as you try different doses.
And secondly, I think this is an area of research that is so important because, as you said earlier, there's so many areas it hits. And we know it when we lose, like everyone's feeling it right now because we haven't had much sleep from last night. And so we feel it. So when you are losing sleep every single day for 10 years or whatever, however old your child is, there's so many negative impacts that has. And so this community is kind of ready and to kind of figure this out. And so when you say in 10 years we're going to have something, how do we bump that up to 2 or 3?
Yeah. So I have a couple of comments. First, I don't know why they always schedule these sleep talks right after lunch, I was focusing on the patients, but obviously there's a huge impact on families too, right? And if you have a kid with behavioral problems and they're up and down all night and so forth, it just drives, runs people ragged. And so this is where sleep clinics are helpful because even as a parent, there's obviously the issues around coming up with the best treatment plan for your kid. But also there's things that can be done to improve your sleep too. And I would, depending on where you live, there's probably a pretty good sleep clinic near you, and they may have some suggestions on ways to improve your sleep.
We're involved with a sleep clinic. We're in Toronto at Sick Kids.
Oh, sure.
With Dr. Narang. And so we have
I know her.
we do sleep studies every year.
Yeah.
I just feel like,
No, I'm talking about for you.
oh, for me.
Yeah, no, I mean, because for adults too, because for instance, one of the things is like if you have to get up 3 times a night because your kid's rummaging around or something like that, there's all kinds of behavioral ways that people can learn how to get to sleep faster, like meditation and relaxation techniques. Everybody's different. Some folks can sort of get up, deal with something, go right back to bed and conk out.
Yeah.
Other folks lie in bed for half an hour, and it takes them a while to settle down. And so there's many, many ways of managing it in all kinds of healthy ways, both for the parents as well as the kid.
So how do we move it to 2 to 3 years?
Oh.
I'm serious. This is like,
yeah.
And not to put you on the spot, but it's such an important area, and we haven't done enough, and I want to push it forward. So whatever you can think of, please share those ideas with Teresa, because we're ready. This community's ready to solve problems.
No, I hear it, and it's not easy to get super quick answers. You want them to be high quality as well.
Yes.
But I think some of I sort of had mentioned a few of what I see as like the low-hanging fruit. Like, first of all, I actually think that just simply our basic understanding of the whole spectrum of sleep issues in the Prader-Willi population could be improved upon a lot. I think there's lots that we don't know, and if you sent out a questionnaire to all the people who were associated with the group and said, tell us about your kids, with some structured questions and stuff like that, so we can say what are really the big things, what are the potentially fixable problems, what are the solutions that people are now using. That'd be a good start. And then another thing, of course, would be to really start to do some clinical trials, to really do some head-to-head comparisons of these things. I think part of the challenge is that there's a lot of variability amongst kids with Prader-Willi, and what works for one kid may not work for another. And so it might be useful to try to say, well, let's talk about a particular kind of Prader-Willi and focus on that.
Thank you.
Sure.
Just to build on what Dr. Scammell was just saying, within the Global PWS Registry, there is a survey. One of the 37 surveys is on sleep, with lots of questions about how your child is sleeping, whether they have narcolepsy symptoms, whether they have cataplexy symptoms. So that would be a great first step. We showed a little bit of data from that, but obviously the more information we can gather, we need more.
I mean,
That's exactly what,
we need the data.
We need the data.
Everybody fill that out.
Yep.
Yeah. You've been waiting for a long time.
I've got a 17-year-old son and with UPD, and because of behavior issues, he won't cooperate with sleep studies. I actually spent a night with him in a hotel room a couple nights ago and listening to him, and he was, moving around a fair amount and snoring lightly. He's always had a tremendous amount of daytime sleepiness. He could always, fall asleep at the drop of a hat. But if kids won't cooperate with a sleep apnea study, are there things can be done for studying simply by observation, or do you treat the symptoms?
Yeah.
And
So now that he's 17, it might actually may be possible to do a home sleep study. I don't know, have you tried that? Or were they trying to do in-lab sleep studies?
in lab.
Yeah. So it's unusual to do home sleep studies.
I don't think it would probably work better at home, though.
It might not, a lot of kids have trouble with in-lab sleep studies because it's a foreign environment. There's a lot of wires and stuff like that. Home sleep studies are done at home, and it still requires a little bit of instrumentation. So there's some bands around the chest. There's a little thing near the nose. There's a little clip on the finger. But it's not a heck of a lot of encumbrance. Again, it depends on the kid and how cooperative they are. That would be a way of getting some data. In the worst case, if you really can't, if he really is like super sensitive to things on his skin and stuff like that, then at the very least, the real sort of poor man's sleep study would be just to simply measure oxygen level overnight with a finger clip. Or they can do it with an ear clip too. If the oxygen level stays nice and steady in the mid-90s all night, if there's any sleep apnea, it's probably not horrible. It's not a substitute for a sleep study, but at least it helps you rule out severe sleep apnea, which is something you'd really want to try to treat. So there's a whole spectrum of ways you could go at that, and sort of working with maybe you have a local sleep doc that you're working with now, but if he's now that he's 17, a home sleep study would probably be something to consider. But also your observations are useful too. If he's just simply got some light, mild snoring and you don't actually hear pauses in his breathing, then that makes me a little less concerned.
It's kind of like snoring, but then I also hear him snorting.
Oh, yeah. That kind of irregularity.
And then
my guess is that if we actually were measuring brain waves during that, we'd see a little teeny arousal, a little teeny awakening. And so that, that is basically him opening up his airway, probably. And so that would suggest that there's some fragmentation of sleep. And, the great challenge, of course, is, all right, so we diagnose it, maybe even treat it. How much of a difference is it going to make? And I think, for severe sleep apnea, there's a lot of room for improvement, and we would really hope that you'd see some important daytime benefits. If it's very mild, maybe, maybe not. So that's where getting some objective data is useful to try to get a sense of where on the spectrum the breathing trouble lies.
Hi, my name is Ashley Brown, and my son Arthur is 2. We've had 4 sleep studies done already. The first time, he failed miserably, and the second time they put oxygen on him, and he did phenomenal. So then 6 months later, we revisited. He's just like, let's just try room air, and it was like almost night and day from the very first one, where it's like everything was just perfect. So the doctor's like, if you have an increase in growth hormone, I want to repeat in a year. And it's like, okay. So we repeated that about 3 weeks ago, and it was like off the charts, terrible.
Bad sleep apnea.
So bad. He had like over 100.
So how old is he?
He's 2. He had over 116 central apneas. I can't even remember all the hypopneas and everything else. But so we went and saw an ENT because he said we need to see an ENT. Which is
He still has his tonsils in?
Tonsils and adenoids
Yeah.
possible. And then they wanted to look at an MRI to do a Kyrie malformation look.
Mm-hmm.
So my concern is, like, what does that matter with the central? And, like, where should we go? Because we're kind of in this stuck place where the ENT is not sure what to do.
Yeah.
On that aspect.
I have to say, I'm a little hesitant. The story is sounding kind of complicated, and I don't really
Yeah.
want to give you
Oh,
concrete
yeah, no,
advice
I just
since I don't know
don't
the
know
full
which
story.
way-
But I think when they talk about doing an MRI scan, what they're asking is a Chiari malformation is sort of a brainstem abnormality that can cause irregular breathing. And I
Okay.
think what they're wondering about is there also, in addition to potentially big tonsils or something like this, is there also another factor that's contributing to the poor breathing? And that's why they want to dig into that.
Okay.
But certainly for most kids with sleep apnea, tonsillectomy and adenoidectomy is the way to go. It's obviously you're talking about a kid who's got other sort of medical problems
Sure,
too, so it's
absolutely.
not trivial like sending a typical 5-year-old to get their tonsils
Right, and
out.
that's where he was at, is like, because
Yeah.
he was like, well, he's kind of more severe high risk, and he's
Yeah.
2. He just turned 2 September, so
Yeah.
when should we try to?
I can't give you a hard answer on that. I think the details are going to have to really go with your local doctors.
Okay.
Yeah, sorry.
No,
but
I
you
was
raised
like, I don't
tough
know what to
questions. Those are
do.
they're good questions, and I think, and also now that a lot of kids are getting started on growth hormone so early, this is when the question comes up quite
Yeah, because
frequently.
they took him off growth hormone 2 weeks ago, and
Yeah.
it's like, we're in this pickle, like, do we go back on, do we not, until
Right.
ENT decides, but ENT doesn't know what to do, so I'm like,
Yeah.
okay.
And were the tonsils really big?
He said it was at least a 2+,
Yeah.
so I don't really know.
Right. That's
So-
medium to large.
Okay,
Yeah.
that's good.
Yeah, probably enough to do something about it.
Okay.
Yeah.
All right,
Okay.
thanks.
All right. Sorry I couldn't help more. Yeah. Sorry, in the back?
So my question is about actually tonsillectomies. My concern is that there might be too many of them happening. I read a review article that stated that they're not as helpful in the Prader-Willi population. I'm curious what your thoughts are about that.
Yeah, actually, I have to say I don't have a strong opinion on that one way or the other. In the general pediatric population, tonsillectomy is well tolerated, and it's often very, very effective for sleep apnea. Of course, it doesn't get rid of it all the time, but it gets rid of the sleep apnea much of the time. I think the complexities, or what we talked about earlier, is that it isn't necessarily just, in the general population, big tonsils may be the whole explanation. You take out the tonsils, you're done. In Prader-Willi, there's a lot of factors that contribute to poor breathing. And this could easily be one reason why tonsillectomy as a whole doesn't treat the sleep apnea as well as we'd like. Yeah. The trouble is, it's one of the more sort of targetable things, and so it's very, people are very eager to do it because the alternatives, like CPAP and stuff like that, that's kind of a big commitment too, especially in a kid with behavioral problems. So.
This morning we were talking about real-life data, and you talked about the pulse ox data with apnea. What are the patterns, and would you collect, real-life data in PWS patients, and what patterns should we be looking for? How quickly does the pulse ox go down? How quickly does it come back? And
Yeah.
should we be looking for patterns like that?
Yeah, well, so pulse oximetry is a very insensitive indicator of sleep apnea. It really will only pick up moderate to severe sleep apnea. You'll completely miss mild sleep apnea. So just to give you an idea of just sort of what the data looks like, a normal oxygen saturation would be around 95%. And if somebody has a complete airway blockage, what you'll see is that after the airway first occludes, within about 15 seconds, oxygen level will start to fall. It generally sort of trails down, and with a sort of a very typical apnea, it'll go down to the mid-80s. Then somebody opens their airway, and it pops right back up very quickly. So you see a slow decline over about 15 seconds, and then a very rapid return to normal. So a bit of a sawtooth shape. So, but I think anybody who really studies sleep apnea would say that pulse ox is a really crude measure. I think that you really want more to get a sense of respiratory effort and how much airflow there is at the nose. Because particularly in children, they don't actually drop their oxygen saturation that much. It only takes the teensiest perturbations for them to rouse themselves from sleep. And so in a pediatric population, they may never drop their oxygen saturation below 90%, and yet they're rousing many, many times during the night because of those airway obstructions.
So you would suggest a vest to measure respiratory
You need
effort?
something like that, yeah. And in fact, what you really need is you need to measure airflow at the nose, which unfortunately I think is a very difficult thing for a lot of kids to tolerate. Yeah, it's a toughie.
Sorry. I think this is fascinating, and thank you so much for your time. I have a 6.5-year-old, so I've had 6.5 years of terrible sleep with her. So I just wanted to hear your thoughts on B12, which I anticipate you're going to say is totally unrelated.
I'm sorry, what was that again?
B12, like B12.
Oh, B12.
Yes.
Uh-huh.
We increased hers and saw improvement in her daytime energy and stamina. And I also wanted to hear if you had any thoughts on caffeine.
Yeah, so I'm sorry, was your child B12 deficient?
Not registering on a blood test,
Yeah.
B12 deficient, but she has a MTHFR mutation, which can lead to B12. It's kind of
I see.
a roundabout.
So you'll have to
tricky thing.
educate me. So I'm sorry, do kids with that mutation, they can have normal B12 levels, but they're not responding to the B12 properly?
Yeah, because it's a methylation with the folate.
I see.
So the folate, and then you can't
All
use
right.
the B12.
You're out of my league on this one.
I
Yeah,
was
sorry.
just-
No, I mean, in general, you know,
I didn't know B12
if somebody's
had any link
blood
to-
levels of a vitamin are normal, there's no need to give them more.
Right.
But if your child is somehow insensitive to B12, then extra high levels potentially could be useful. But in general, B12 doesn't actually do a whole lot for arousal and sleep.
That's what I was.
It sort of works in different aspects of body physiology, but people who have very low B12 or very high B12 generally have normal sleep and wakefulness.
Okay.
What was your second question?
Caffeine.
Yeah, so caffeine. So of course, you know, caffeine is the most common wake-promoting drug, right? You know, most Americans drink some coffee or tea or something like that. The trouble with caffeine as a therapeutic agent is that the wake-promoting effects fade very quickly. And so, for instance, if you don't drink coffee at all and then you drink 2 cups of coffee, you are going to be wired. But if you drink 2 cups of coffee every day, you're not going to feel it at all. And so your body's system actually adjusts to it. If you're interested, caffeine blocks adenosine receptors in the brain, and your brain compensates by simply making more adenosine receptors. And so it all kind of irons out. And this is the same reason why if you drink a lot of coffee Monday to Friday and then stop on weekends, you can get headaches and feel tired and stuff like that because your brain has already sort of recalibrated over those few days. We almost never use caffeine in a sort of a medical therapeutic way because of that rapid development of tolerance. Yeah.
Hi, thank you. My name is Ann Bateman, and I'm with the Latham Center. I'm a advanced practice nurse psych prescriber. So I do the psych consultation for the Latham system in Southern Mass. And one of my questions is, as many of you know, I'm sure many of the parents know, the whole world of prior auths is like the bane of my existence. And I always feel sort of reluctant to talk about new vigil or provigil with a parent because I can't really remember ever being able to get it approved.
Oh, really?
And I was just wondering if there's a secret code that I haven't found in the DSM-5 or the ICD-10
Yeah.
that might get it past the powers that be?
Well, so modafinil costs about $400 a month. It's not a cheap drug at all, and it's no wonder that insurance companies throw up these barriers. And so oftentimes on a prior authorization, there's a little box. Is there anything else we should know? Because quite frequently what they want is they're gonna say, well, why don't you just give this cheap, methylphenidate or other amphetamines that have been around for 60
Right.
years because they're so inexpensive. And you've got a ready response. You can say, this kid already has horrible anxiety, they've got OCD, they've got behavior problems, they can't go to sleep at night, whatever it is. And I think if you spell those things out, unfortunately, you might still have to do sort of one of those verbal appeals on the phone.
Those are
But-
actually more successful than,
They usually work.
the written
No,
word,
I mean, because,
right.
honestly, I think a lot of the times with these prior authorizations, they're not ultimately trying to stop you from prescribing the medicine. They're just making it really hard. And so it just takes tenacity on the part of the families and on the providers to really just push through. I can't think of a patient where I've not ultimately been able to get them modafinil or Nuvigil. And it's usually one or the other is the cheaper version on that particular insurance plan.
depending upon the plan.
Yeah, I think you may just need to start making some phone calls to just knock down the doors.
And just to add to that, so there are at least 2 published studies using modafinil in PWS, and so I know some families have found some help in insurance appeals by providing those, and we can get you those, but I mean, they're readily available. And so if you put the appeal in with a study that is specific for PWS, then sometimes that's helpful.
Yes, they do love it when you quote the data.
Yeah, yeah.
Yes,
Right on.
So,
great.
so we're going to need to wrap up. Do we have one more question, or
We'll go together. How's that?
you can ask?
For family. So number one, we tried melatonin. We tried it ourselves
So-
as adults.
So just tell me, what were you trying to accomplish for your kid?
Yeah,
What were you trying to accomplish with the melatonin?
to sleep deeper at night and stay asleep for longer.
Okay.
Because we're finding as we share stories with each other that they go to bed early at like 8 o'clock and then they're up at 5. And it's this internal clock they always. So we tried it ourselves, but we felt groggy in the morning. That was me personally. We tried it with him. We didn't really see an improvement. What are your thoughts on melatonin was my first question. And then the pitolisant that you put up earlier. Could there be other benefits from pitolisant that could improve other areas in PWS? And I know you can't really know until you study it, but
Yeah.
because it's a different pathway than Provigil or modafinil.
Yeah, I think with pitolisant, it's the clinical studies have only been in narcolepsy, and so whether it has any sort of cognitive or behavioral benefits is just it should be complete speculation at this point. And I don't think one can really even make any predictions because, as I said, it affects all these different chemical systems. It almost certainly increases histamine, but it's likely to increase the levels of those other chemicals too, the norepinephrine and the serotonin and dopamine and so forth. And so I think it would just be speculation on the pitolisant.
Okay.
But to get back to the melatonin question, so melatonin is what most pediatric sleep specialists prescribe for kids who aren't sleeping well. And the reason they do that is because it's like the most benign sleep-promoting drug that there is out there. But the trouble is it's actually not a sedative in the typical sense. So if you like Valium or Zolpidem, Ambien, these medicines enhance GABA signaling in the brain, and they're just downright sedating. They'll knock you flat if you take enough of them. But you could take a bucket of melatonin and stay awake. What melatonin really does is probably the most proper term for it is it's not a sedative, but it's a chronobiotic. It's a drug that basically sends a signal to the brain saying, this is nighttime, this is when you should go to sleep. And so the way that it's helpful is that it basically it's like ringing the bell and saying, this is bedtime. And so when people take it about 45 minutes before lights out, their desired bedtime, you get these nice high levels of melatonin in the brain, and it helps entrain a normal sleep cycle. And if you pair that with a regular waking time in the morning and getting some bright light, you basically have sort of bracketed things. So light in the morning to say, here's daytime, melatonin at night to say, here's dark onset, and this is when you should go to sleep. What's funny is that some people do find it kind of sedating, and I can't explain this at all. It's funny that you would feel groggy with it, but Most of the time, I can tell you, like for instance, in most patients with insomnia, it's really weak medicine. But it's
So
good for
just to-
it's good for establishing regular sleep patterns. That's what it's really
Just to
helpful
piggyback
for.
quickly, that was what we were talking about, is I find that if we give our children daytime arousal medications, can we not just focus on getting better quality REM sleep at night? Because I find my daughter during the day, when she's tired, she's just irritable and raising hell. And if we go on a long drive, she sleeps the whole time.
Yeah.
And then she wakes up a different person, so.
Yeah, you know, actually, when I was driving down here, I just remembered there was a slide that I meant to put into this that I completely forgot, which is behavioral management of sleepiness during the day. And for most kids who have chronic problems around sleepiness, we really actually do encourage 1 or 2 short naps during the day. And so if you could make that part of the daily routine, because if the kid only sleeps maybe 15 or 20 minutes, you know, maybe late morning and then mid-afternoon, that's often great for charging their batteries and helping them get through the next several hours. And it's a way of also minimizing the drugs. I'm sorry, I forgot to mention that earlier. But the behavioral management, it can be super useful.
And there's no current method known to encourage REM sleep.
Not REM sleep specifically, no. But you know, also, I think when I was showing that slide of all the consequences of insufficient sleep, that was speaking about sleep in general. And so anything that we do to just increase sleep in general is also going to increase REM sleep. Yeah.
Hi, I have a 6-year-old. He had a TNA last year, and we've done the sleep studies. They show fine, but we're still having a lot of nighttime wakening.
Yeah.
Is there
Sorry,
any-
so the sleep apnea has gone away now?
Yeah.
Great. Okay.
So we're looking at acid reflux as
Yeah.
often, but is there any benefit of still having him on a CPAP, just keeping that airflow potentially?
Sorry, is he on CPAP now?
He's not. We have one from way back when he used to use it.
Yeah, well, if his most recent sleep study showed no sleep apnea, then the CPAP is just superfluous. And it's just one more hassle in the overall picture of things. However, if he's still got some mild sleep apnea can actually make reflux worse, because when a kid has got a blocked off airway and they're trying to take a breath, it can actually draw acid up. And so if the docs say that the sleep apnea is really gone, I don't think you need the CPAP.